Welcome to this week's episode of Promising Young Surgeon. This week, Dr. Stefanie Simmons joins us to discuss her own mental health journey, as well as the incredibly important work that the Dr. Lorna Breen Heroes Foundation does to advocate for physicians and destigmatize seeking mental health care. So we'll start with an introduction to the Dr. Lorna Breen Heroes Foundation. Many physicians do not seek care for mental health concerns due to fear of impact on future career, licensing, and credentialing. For instance, because not everyone may have seen these questions before, the application for a license to practice with an MD include, have you ever sought treatment for anxiety or depression? The foundation's mission is to reduce healthcare professional burnout and improve well-being. We envision a world where seeking mental health services is universally viewed as a sign of strength for healthcare professionals. One of their major initiatives is removing intrusive mental health questions from licensure and credentialing applications. As of April 1st, 2024, 27 state medical boards had changed their language on their licensure applications, and 11 more states are in the process of making these changes. 19 health systems have also changed their intrusive language on the credentialing applications, such as HCA Healthcare, MedStar Health, with an additional 18 health systems in the process of making these changes, such as Children's National Hospital, Johns Hopkins Health System, and Mass General Brigham. To provide an introduction to Dr. Stefanie Simmons, Dr. Stefanie Simmons is an emergency medicine physician and healthcare executive. She is the chief medical officer at the Dr. Lorna Breen Heroes Foundation. She obtained her MD from University of Michigan and completed her emergency medicine residency training at the University of Michigan St. Joseph Mercy Medical Center. She is the vice president of clinician engagement for Envision Healthcare's National Medical Group in Ann Arbor, Michigan. Thank you so much for joining me today, Dr. Simmons. Welcome to the show.
Thank you. It's really nice to be here. Please call me Stefanie.
Okay, absolutely. So Stefanie, it's really a pleasure to have you on and to share your story and the critical work that you do. I know that you're a very strong advocate for physicians who feel like they can't seek mental health care due to concerns about their future licensing, implications on their career, and also just the stigma surrounding mental health. What led to your dedicated work in this area?
Thank you for the question, Frances May. This issue has really been with me from the beginning of my training as a medical professional. And what happened was really in the first weeks of my internship, my best friend, my fast best friend, as often happens in internship when you meet someone and you just click. His wife was pregnant, and so was I, as interns, and she had a crash C-section because of HELLP syndrome, and so he had to start his internship with a premature infant and a wife in the ICU. That the baby actually came home before his wife was able to come home. And so he would bring her to lecture, and I would sort of incubate this baby on top of my pregnant belly sometimes to give him a break. And I watched what he went through, and I frankly thought, as a residency and as a profession, we could have done better in supporting him and his family. Another one of my friends during residency developed encephalitis from her pediatrics rotation and was left with a seizure disorder after that experience. And so, again, I felt like the support and the acknowledgement of the additional struggle that she was experiencing there could have been more support. And it really brought to me that we have this crucible that we go through in residency, this transformative experience where we're really embracing our profession and learning the craft of our profession. And there hasn't always been a place for a lot of life to happen in there along with those experiences. So it was in my 4th year of residency when life happened to me big time. So I had a 3-year-old and I was pregnant with my 2nd child, and I developed really strong depression during my pregnancy and afterwards. So I knew that I was at the end of my residency career and I was about to start work as an attending. I knew that I was going to be asked about any excess leaves, any mental health care, and I really had a lot of fear about what those questions would mean for my career. Now, this is 17 years ago at this point. Easy to remember because I just need to remember how old my 2nd child is, right? And I didn't feel like I could seek care. And to be perfectly honest, I had a rockier first few years of my career than I needed to because I did not seek care at that time. And in retrospect, I know that things would have been better for me, also for my family during that time if I had. And so it was really the culmination of these 3 experiences together that from the first few years of my career just really focused me on how we can do better as a profession at caring for ourselves as well as each other.
Absolutely. And thank you so much for sharing. I'm sorry that you went through that personally. Plus, it's harrowing to hear about what your co-residents experienced during training as well. I do have, a couple follow-up questions about that. Do you feel like once you were in your early career attending position and already licensed, credentialed, certified, then did you feel like a switch had flipped or that it would be suddenly more accessible, reasonable to pursue healthcare?
I did feel more secure in that at that time. And there were a couple of things that helped with this. One is that one of my leaders at my site, I believe at the time would have been our medical director, and later became our chair, was very open about their mental health journey and that they had been in therapy, that they had experienced anxiety, and that made me, I had nothing but respect for this person and their clinical skills and their leadership, and knew that they were highly regarded in our organization as well. And that helped me to sort of understand that I would be able to get some help and it would be okay. So when I think about stigma, I think about 3 different types, right? There's institutional stigma, which are the rules, the questions, the regulations, the applications, right, that stigmatize mental health care. Then there's internal stigma, which is what do I think it means about me to have mental health care? And then there's external stigma, which is, what do I think other people are going to think about me if I have mental health care? And so once I was past that first hump of exiting residency and being an attending, having seen what the licensing questions were and what the credentialing questions looked like for the first time, and then also hearing from my colleague about their journey, all of a sudden it became a lot less scary. And one of my goals throughout my career is like, can we make it a lot less scary from the beginning?
I love that. That's definitely the goal. You were in a union residency. How did that affect like maternity leave in your case? Or I don't know if your co-resident was able to get paternity leave when his family was so ill and everything like that.
Yeah, so that's a great question. And my residency has had a resident union for a very long time. This was not new, even 17 years ago for our program. And it was highly, highly regarded both by the residents and also by the university. I did have maternity leave. I had 6 weeks of maternity leave, which, I realize even now is the exception, not the norm. I did have to make that time up at the end of my residency, but that also was okay. The one thing that did happen for my colleague is the healthcare coverage did kick in for him and his wife, even though like she was pregnant before he started work, right? And so from that perspective, the sort of letters of the law were followed, and there were systems in place that supported us that may not have been there had we not had that advocacy on our behalf. And I'm very thankful for that time away and for those supports. Having said that, where I felt like there was a real opportunity was really in the attitudes towards the residents who did experience difficulties. Myself, and I'll speak for myself here, not my co-residents, but if anything, I graduated residency and started practice with a better understanding of my patients than if I hadn't gone through my postpartum depression. And particularly in the emergency department, where we take care of a lot of patients who are having mental health issues, my understanding of the just really concrete physiology that can drive that phenomenon was much better. I am somebody who had always sort of had this naturally cheerful affect, and may have had a down day or two, but never had experienced how your internal chemistry can just rock your world. And starting my practice, I had that experience, and it really did help me with empathy and compassion for others. And so rather than viewing these experiences as detracting from our ability to be professional physicians, they really added, at least to mine.
Absolutely. I definitely agree with that sentiment. But in terms of the attitude that does need to change, I agree that there's a way that we could culturally be a little bit more gracious and understanding towards like our colleagues. And so one example that I'll give of that is where I've spoken to a resident before who did take a mental health sabbatical, program sanctioned and everything, certainly set up through the PD, all official channels, very significant clinical need for that. Upon returning to the cohort, overall, a lot of people made no comments, which that's better than saying something unkind. But multiple people did say, "Did you enjoy your vacation?" Yeah. Those types of comments. And that's such an easy way to kind of be passive aggressive at the hospital. But I do think that like the whole physician workforce, the whole healthcare workforce benefits from elimination of those kind of takedowns of people who are seeking help, for clinical conditions and things like that. So I definitely agree with you on that. I do want to highlight like the framework that you described, that 3-pronged problem that physicians face. So number 1, internal stigma. Agreed. And I mean, I'm sure you and I could talk for 5 hours just on the internal stigma. There's number 2, the external stigma. There's also, as part of this external stigma, we do seek advice from our peers and things like that. And often it has been my peers in healthcare or other physicians who are telling me, "Oh, you better not. Like, I would not recommend that. Squash it down, for at least a few years." And number 3 is the institutional stigma. And I know that today I'd like to focus a lot on number 3, the professional stigma, the institutional. And what I think was so beautiful about your story is that you talk about being in a department where the leader really was a phenomenal role model. Like they talked openly, they led by example and made their constituents, feel comfortable while also being a phenomenal physician and everything like that. So I don't think that can ever be discounted too much, especially in surgery. I will say we see a lot of people who sometimes they act like they came out of the womb this way, just like perfect. The world's best surgeon, the world's best hands, which I have so far, not seen on a baby. And then they act like the process, the crucible to get there didn't happen. Yeah. And that, that's kind of a disservice to the next generation and like all the young people who look up to them and they try to emulate them and they try to imitate that path.
That's right. I have this mental image, Frances May, of someone saying, like, I actually performed my own C-section. That's I think that's
Yeah.
where it came from me. Yeah, so it is interesting, and specialties tend to have different cultures, right? And I would say, emergency medicine is definitely not known for being the kindest, gentlest specialty either, because we really pride ourselves on being able to handle anything, anywhere, anytime, right? Anything that comes through that door, I'm at least going to be able to stabilize and get to the right place. And so the internal component of that is you're like, okay, well, if I am supposed to be that for other people, right, then I should be able to be that for myself too, and take care of anything, do anything, handle any problem on my own independently. And any strength, when it is taken to an extreme, becomes a weakness. So that self-sufficiency becomes a weakness when you actually do need help. And every human being, and we are social creatures, and every human being in their life is going to come to a point where they need help from somebody. And if you don't allow yourself to get that help, to have those conversations, even asking your loved ones for help, right? Your parents, your siblings, your significant other, for their help, then that becomes a critical weakness in you. And, there's those strikes that we have that we've been selected for in medical training, right? You don't get to medical school unless you are a perfectionist who likes to work hard, who's driven by achievement, and maybe even a little compulsive about ticking all of the boxes and crossing all of the T's and dotting all of the I's, which are strengths that you need in medicine. You need to check and double check your orders. You need to like to work. And if you're writing orders on my kid in the hospital, I hope you're a perfectionist, right? So those are all good qualities. But if you take those tools and you use them in every single situation in your life, being self-reliant doesn't work very well in a marriage. Being a perfectionist doesn't work very well when you're raising teenagers. I'm here to tell you, as a mom of two kids, two teenagers and a younger kid right now. So those tools need to be put away in favor of other tools from time to time.
I love that. That definitely resonates with me, and what it became, the way that manifested when I was a resident is that, ENT residency is a lot of airway emergencies. It's a lot of potentially very dangerous, high acuity types of like consults, pages we were getting, things that we were dealing with. And not only that, but then there's all the other grueling hours and call, even when it's not immediately life-threatening in the next couple minutes. And in totality, I did internalize that in this way where it did spill outside the hospital because I couldn't tell what was an emergency anymore. So like, something in the house breaks, or, like something small with the lawn, like it was very difficult. And I kind of had to spend years untangling. Like, most things are not a big deal, but it's very true. Some things are an enormous deal, especially primarily, the detail-oriented work we do in the hospital, like attention to orders, attention to surgery, attention to post-op care, things like that. But it's interesting because it's obviously not part of like the taught or modeled training in terms of like, hey, be mindful about this. Like, make sure that you don't start treating everything this way, right? Because you are not just an ENT, and if somebody is firing on all cylinders 24/7, they're not going to make it.
Yeah, it's almost like your scale gets changed, and for me, it was almost, if I'm understanding you correctly, it was almost the opposite for me, where all of a sudden my level of what constituted an emergency went way up. Right. And so because I was every day at work dealing with people who are trying to die and really critically injured and ill patients, when I was outside of work, it was really hard to get my attention. Right. Because, I think if you ask my kids, the quote that I quoted to them most frequently growing up is, nobody's dying here, right? Or like, it's okay, all bleeding stops eventually. You're not hurt that bad, and so for me, it was, okay, how do I adjust my scale back to normal levels when I'm not at work dealing with critically ill, so that I can give the things in my life, my relationships, my fitness, my diet, like all of those things, the attention they deserve, because I was either off or on. And I wanted to be on for my life outside of work too.
Yeah. And I think that it's interesting for people to realize how differently these things can manifest. Cause I totally agree with you. It's almost like inverse experiences, although we both maybe didn't feel like we were our best and most mindful selves in life outside the hospital. And I do think that part of it is that we did take home call and things like that. So in terms of like lines being blurred,
yeah,
we were, there wasn't really an off unless you really had call coverage or had somehow like left town or things like that. And so I just think it's very easy. Like my takeaway is just that it's very easy for any physician, any resident to have like a deranged balance between like whether they are overcalling, hey, this is a big deal, or if nothing is a big deal to them. I just think that being more mindful about it before we even develop certain habits during training, like that's awesome. Any bit that like even younger people can kind of go into residency being like, I actually heard like this could be a pitfall. Maybe I should look out for that. And if I start to see myself going the wrong way 1 year in, I'll intervene.
Yeah, another place, because I love that idea, is like what can you sort of be on the lookout for, right, in yourself and in your friends, to be like, oh, hey, you're doing that thing. Another thing for me was, as you're developing your professional identity and your team leadership, we operate in some pretty hierarchical ways in the hospital. And some of that has broken down in a very positive way over the past 20 years, but some of that still definitely exists, right? Just think about the phrase giving orders, right? So I'm going to write my orders. What's an order? You are telling somebody to do something. You expect them to do it, right?
Yeah,
you
that's true.
You get home, that no longer flies in a relationship. And so one thing that I noticed in myself, I definitely got called out on at home and have had to be careful with over the years is, hey, when you get home, there are no orders, right? So let's have a collaborative conversation about how things are going to get done. And that's with your significant other, but also with your kids, also with your family. And so that's one thing, as you get acculturated to this medical hierarchy. First of all, question when it's helpful, even in the hospital, because the answer is not always, in terms of psychological safety and culture of safety. But then definitely be aware of when you're bringing that home and how it may be impacting your relationships. And I'm happy to say, like, I married my high school sweetheart, Frances May, and we're still together. So like everything worked out, and something to look out for and watch for.
Yeah. It reminds me of a story that actually one of my favorite attendings told. Really loved this attending, incredible surgeon, like hard worker, crazy work ethic, just a true surgeon. And they had gone on a friend's birthday party. So like a rare event, which is like left town for a few days, reconnected with the college crew, came back. And so we're operating the next week. And of course, I was like, oh my gosh, how was that? That's awesome. You got the crew back together. And again, like this person doesn't leave town a ton. I don't think that they're like frequently meeting up with the college crew. And their response was, I actually, like the craziest thing happened. I got kind of miffed because we were all talking in a group and people were not listening to me. And I kind of was like, I'm the attending here. Like, what's up? Like everyone be quiet, because they were truly so used to it. And like, absolutely all of us, like, adored this attending, but whether or not you adore the attending, you are pretty much there to make their life run as smoothly as possible. That's how we were trained. And like, everyone's at your beck and call. And also no one would ever, ever, ever talk over you. So it was so funny to hear their perspective that their friends were like being disrespectful. But I love that. Like, yeah, your friends don't care that you're an attending. Like none of them, they're not in medicine. This is just the college crew.
It's super important to have those relationships where you're not in that physician mode. Whether it's at the gym or with your family, with your friends in the neighborhood. It's not that you can't tell people what you do, but like, I want some place where I'm Steph and I'm not Dr. Simmons. I want some place where I have to maintain my non-hospital social skills. It is a different social skill set. And for a lot of us, we spent college grinding and medical school grinding. And it's not to say we didn't have a social life, but we didn't always develop the complex emotional intelligence skills that some of our friends who maybe went into business, right? Or went into other types of programs, even like teaching and, more relational fields have had to develop over time. We have a really specific, highly honed set of relational skills, but they're not necessarily generalizable. And so I love the idea of, hey, maybe don't make the first time you hang out with those folks, 5 years into your attending career, make sure you're keeping those relationships going and making time for people. If nothing else, they will keep you humble and remind you of where you came from.
Yes, that's so true. Well, to switch gears a little bit here, I did want to make sure that we honed in on resident-specific issues as it relates to some of these questions. So program directors have to fill out evaluations at the end of residency, including notes regarding performance improvement plans, significant interpersonal issues, and any impairments to physical or mental health. Mm-hmm. So I'd love to hear about your call to action for program directors, because obviously, even separate from the licensing credentialing questions, we have this legal document.
Right. It's a great question. I would love to see every program director answer the question about impairment only. For instance, if you can with clarity and with confidence say, this resident is finishing residency and is not impaired in the practice of medicine, then you should. And if you know that resident had mental health care during residency, if you know that they have a diagnosis of a mental health or mental illness during residency, but have not been impaired, are not impaired at graduation, to me, that's the question you should be answering. Are they impaired now? And, I do know of residency directors who are conscientious objectors to that question and say, at this time, this resident has no impairment. And, if they've had a formal leave, I think they still will disclose that. But if it's mental health care, just like physical health care, if it's not impairing, it's sort of just that person's private business and really doesn't belong on that answer. And so what I would love to see our program directors do is have some solidarity with each other and with residents in how they answer, and really only answer the question to the extent that's needed, which is about current impairment. That would make a big difference for residents' willingness to care for themselves. And it also needs to be backed up with real access to resources during residency, right? Can a resident actually access resources on their timeline, right? On when they are available to receive care? Can they do that without it being part of their evaluation of their performance, right? Because I think what everyone's fear is, okay, I did great on the shelf, I did great clinically, but I had to take an hour at the end of every other Thursday to go see my doctor. And is that going to make me a bad resident in the eyes of my program? And so program directors really need to develop that culture among their faculty, right? Some of whom may feel otherwise. So they need to develop that culture, and then they also need to push back if the questions that they're being asked to answer at the end of residency are more invasive and stigmatizing than necessary to ensure competence and lack of impairment.
I agree that often, or at least in what I've seen personally, a lot of the pushback is from faculty. And often the rhetoric is something like, my clinic can't go uncovered, or, like a case is going uncovered or something like that. And so, especially in a smaller residency program, that does come up a lot. I do talk to or connect with different resident physicians who have personally, like totally separate from the program, separate from residency training, because they are trying to keep things, like under wraps, where they reach out to private therapists and they no-show 3 visits. And that's because the OR runs later than expected. And so what's really tough about that is that it's not even a late cancellation. It's a no-show at times, because I can't imagine, super unpractical to be like, I got to scrub out of this case to cancel therapy for tonight. Like, you'd just be throwing yourself to the lion's den saying something like that. And so, but then in that case, like I spoke with a resident physician who then got fired from that practice. It was 3 no-shows, never even met the therapist because they're a very busy, on a demanding schedule. And so I know that there are programs out there. There are some like therapists who specifically, they do specialize in physician healthcare, resident physician healthcare. So they have like these evening weekend hours that could maybe work around the regular workday and call. But what options do you see as being very practical for these people?
So there's a couple of options. First is just know what your institution offers, because you may assume that there aren't resources, and there may actually be some there. So I'm going to talk about a couple of different tiers of options for folks. Almost every organization has an employee assistance program, and they will offer 5 visits typically. These are typically like collegiate or master's level trained counselors, and they are focused on acute issue for five visits. That will remain private to you, that you access that care in most organizations. So that's one option, and they do offer therapy over the phone, and typically at off hours. But again, make sure that you are asking about general information so you know what is disclosed, what isn't first. The second option that has helped some people are asynchronous app-based therapy options like Talkspace or BetterHelp or Meet Marvin. And I do not have any financial relationships with any of these, but I do know people who have found them helpful because it is a chance to meet and talk outside of hours. For all of these options, you are typically not meeting with a doctoral level prepared counselor, therapist, or psychiatrist. But there are programs that do have that. So learn what's available to you through your insurance and through your program. It's probably a half an hour of research on the internet while you're on call one night to figure that out. Or if you do have a residency navigator for well-being or a union rep, that would be a great place to go for those resources as well. After that, consider looking what else is available through your insurance that you are provided through your employer, because that may extend outside of your organization. So it may not be, the psychiatrist that you're going to be rotating with 3 months later. There may be an extended network available to you. And I'd encourage people to see what's out there. There is a mental health care shortage in our country. So sometimes, regardless of ability to pay, the options are a little sparse on the ground. Another option is peer support programs. And so many hospitals and health systems will have a confidential peer support program where you can connect with a peer within the organization. And that peer support is maintained as confidential unless it reaches the level of harm to self or others, right? Just like it would for any conversation in mandated reporting environment. So those are other opportunities within hospitals and residency programs to look for.
That's awesome. Thank you for sharing all of that. And I had heard of, maybe like 75% of it, but it's always good to hear from experts about everything. And it's really tough because, it isn't one size fits all. Like not every institution is the same. In terms of one thing that I learned only as a chief resident, but found very helpful, I was recommended to check out the graduate school program, like associated with the big university and the big hospital, because the grad school did have PhD students who ran their own DBT skills group.
Oh,
and that's how, it was awesome. It was once a week, $20 cash at the door, like that, to do very small group based, like a true DBT skills. And the leaders of the group, there were two of them, they were both phenomenal. Like they were really brilliant. I personally think that they did an excellent job of like teaching DBT skills. And again, at what I thought was a fair price, it did not talk to the EMR at all, because when you're a resident, like one of my first questions was, does this talk to our EMR? Like, is this documented anywhere? But, that skills group was just such a great experience. And it's what inspired a lot of like, the brand I created, Rethinking Residency, everything like that. Because what's so funny is I was a fifth year when I heard all of that. And, I hadn't heard anything about like distress tolerance, emotional regulation, interpersonal effectiveness. And even from day one, they were introducing these concepts. And I was looking around and I was like, where have you been this whole time? Like,
why isn't this core curriculum? Yeah, why isn't this core curriculum?
Like truly, it was going down the list of probably what I could have identified even years before of like, these would be a superpower to a resident. They certainly would have helped me handle things in a healthier way and process things in a healthier way. And also just, get through tougher situations, like kind of with aplomb. Like there's such incredible things to master. And I will say that I traveled last week and gave a grand rounds. I gave several resident lectures on interpersonal effectiveness. And I just say, I'm giving this talk, in my capacity as a surgeon who learned these skills. I think they're very applicable, particularly in the OR, as I did many anesthesia resident lectures. And I'm not even kidding. At the end of my last talk, a chief raised her hand and she was like, I really liked this. And she said, I wish you'd come here sooner. I wish I'd heard this sooner. I was like, you and I are of exactly the same mindset then, because she experienced the same, like just, she would be almost graduating now. And she just was like, wow, wish I heard this a couple years ago.
Yeah, but better late than never. And what I would say is I learned those skills a few years after graduating residency. So, head start in some ways. I agree that we need to get this much earlier, probably exposed to it the first time in medical school and then booster shots, right, in residency. Frances May, there are two more resources that I forgot about that I want to mention. One is Emotional PPE, which was an organization started during the COVID pandemic, but that offers counseling and therapy to physicians across the country. And then the other is a physician helpline, which has trained psychiatrists. They do have more limited hours, but they do have hours. They are free. They are anonymous care options for healthcare workers as well, and available via a quick online search. There's another place to get some of this, and that's with coaching. Coaching can be very attractive to physicians because there are a lot of physician peers doing coaching out there, and it's not mental health care. It is someone who is trained in helping you identify some of your own beliefs, right? And ways of thinking about things. So coaches can be thought of as thinking partners who have some training and who are interested in helping. And for many people, that is a really great option, particularly if you're sort of mired in a specific way of thought in residency. Now, coaching is also not highly regulated, right? And so it's worth talking to a prospective coach about where and how they are trained and how coaching they have, so that you know what sort of training they have, and before you get into that relationship.
Yeah, that makes sense. I've definitely seen some heterogeneity across across that market. If somebody lives in a state where intrusive questions are still on the applications, like let's say that they're not in the 27 where it's changed, 11 where it's pending, then what advice would you give that person who maybe has been thinking, oh, I want to seek mental health care, but I'm uncomfortable, I have hesitations. What would you advise them modern day?
That's great. Great question. I've got 4 things, boom, that I would advise. The first thing is get help. Don't let that dissuade you from getting help. Get the help you need, because we don't want to lose you, and we don't want to lose part of you either, right? So obviously we don't want to lose people to suicide, and that happens, but we also don't want anyone to live a life that's limited. That doesn't have to be, right? And so please, please, please get help. Once you've gotten help, think about how you are going to communicate that help. And if you have a very great program director, they may be able to help you with this as well. But you can also contact legal services. You can work with an employment lawyer and write up a paragraph about what your experience is. If you are not impaired by the help you are getting, or by the diagnosis you have, then you need to be able to communicate that you have engaged in self-care to prevent impairment and that you are not impaired. The Americans with Disabilities Act exists, right? So if you have a need to receive care for a diagnosis, you have, you should be able to get that care, and you should have reasonable accommodations made for you to receive that care. It can be helpful to write that up ahead of time, so that if you're asked to communicate what care you received and how you received it, you know how you're going to communicate that already. The third thing you can do is you can write your state medical board and ask them to change their questions. We know of several states where medical students and residents have really led the way in asking for those changes and articulating the need for those changes. Minnesota is one of those states where students they're actually residents now, but students led the way to get those questions changed. And your voice is very powerful. If I'm a 47-year-old physician with 3 kids living in a city, I'm probably not just going to up and move on a whim based on what state has which questions, right? If I'm just starting my career, that might be something I can consider. And if it is something you would consider, articulate that, because we have a workforce shortage, and states do not want healthcare workers to go somewhere else because of something simple they could change. And this falls into that category of something simple they could change. So there's a way actually on our website to write your state medical board, for nurses to write your state nursing board. And you can also start state legislation to fix this problem for all licensed healthcare workers in your state. So we've been talking about physicians today, which makes sense, but all licensed healthcare workers actually face these questions. And so when states have taken this up as a state legislative issue, including all licensed healthcare workers, is the fair thing to do, right? We want all of our teams to be safe and feel comfortable seeking care. And there are several states that have laws currently in process. Delaware, Michigan, Iowa, Idaho, all have these in process. Virginia has passed theirs to limit these questions. And so I just encourage you to seek care, think about how you communicate that, and advocate for change.
Well, that leads us very beautifully and very naturally, because I will say we will have the link, of course, to those resources at the bottom of the podcast and everything. And so definitely encourage people to check out what you're describing, the ways in which people can get involved and advocate or write to their own legislatures, especially if you live in one of those states where the change still needs to happen. The intrusive questions are still there. So they have a beautiful map on the website. We'll get that all linked up for you guys. I just wanted to kind of close out our discussion with a focus on Dr. Lorna Breen Heroes Foundation. Of course, I did a little introduction, but I think for people who haven't heard about like the conceptions, some of the major initiatives they can get into right now and ways that they can get involved, I'd love if you would share it with us.
Sure. A lot of people know Lorna's story, but I think it's worth hearing just as how the foundation started. Dr. Lorna Breen was an emergency medicine physician practicing as the department chair at New York Presbyterian Hospital in Manhattan. Came back from vacation with her family for the first wave of the pandemic to treat patients. And she led her department through those first several weeks, actually contracted COVID herself, came back right away as soon as she had been afebrile for 24 hours, and couldn't keep up when she came back because she was still suffering from the sequelae of her infection. She eventually had to be removed from New York and receive care in Manhattan for what likely was neuropsychiatric sequelae of COVID infection, and was so burdened by the concern that she may not be able to practice again after her first ever treatment for mental health, as she died by suicide. And her cause of death and her story was published in the New York Times less than 12 hours after her death, against the wishes of her family. And what happened after that was an outpouring from healthcare workers across the country and even the world to her family, sharing their stories, sharing that Lorna's concerns are not unique, sharing that burnout and workplace challenges, including excessive administrative burden, difficulties in accessing care, existed before the pandemic. Actually were identified by the National Academy of Medicine as a pandemic before the pandemic, and just a few months before, in sort of a prescient. At the same time, their Virginia Senator Tim Kaine contacted Lorna's sister and brother-in-law. She was a Virginia native, and so were they, and offered his condolences, but also asked what could be done. And so that started the foundation's relationship with the Dr. Lorna Breen Healthcare Provider Protection Act, which was passed in 2021 and funded projects and programs to address professional well-being for healthcare workers, including the Workplace Change Collaborative, which is 44 grantees for projects and programs around the country, and the Impact Wellbeing Campaign, which was performed in partnership between NIOSH and the Dr. Lorna Breen Heroes Foundation. The Impact Wellbeing Campaign is 6 steps that hospitals and health systems can take to address professional well-being. Step number 3 is fix your credentialing questions. Like, don't ask these questions of people. Let them seek care without being worried about having to disclose it when it's not necessary. That law is actually up for reauthorization and refunding this year. So another thing you can do on our website is to write your legislator, your representative, to support that reauthorization and funding. As a foundation, we advocate for reduction of institutional stigma and for state and federal laws that support health workers. We raise awareness about mental health and burnout, and we advance solutions. So we help advance the best practices and solutions that are evidence-informed, that have been shown to work, and we help promote those at the institutional, state, and federal level.
Well, thank you so much for kind of the thorough explanation. Dr. Lorna Breen's story is extremely powerful, of course, and what the foundation's work is doing is very impactful. Like, I think that even as a person who is now early career, like when I first learned of the foundation, saw the work it was doing, it did inspire hope. Because, we could see the change happening. Obviously, your guys' resources are like extremely high quality, evidence-based, and it is such a large scale, incredible movement. So, really appreciate you kind of going over all of that with us. I do want to close with our recurring segment. Do you believe in karma?
Do I believe in karma? That's a great question. I think I have a very rudimentary understanding of what karma means, probably more of a pop culture understanding than anything else. And so I'll answer on that level, and you can take this answer for what it's worth. I believe what we put out into the world comes back to us. And if you face the world with an open attitude and optimism and in a sense of the goodness of people, that is often what you'll experience the world as. And so in that respect, I guess, yes, I do.
I love that. Yeah, that's my understanding as well. I'm certainly not an expert nor like a Zen guru. Thank you again for joining me today. And it's been such a pleasure to chat with you and learn more about this incredibly important topic that affects so many physicians today.
Thank you.
Follow me on Instagram at francismay.md and at Rethinking Residency. Visit my website, rethinkingresidency.com, to learn more about resident physician stories and ways that residents can most effectively navigate the game of residency. I cannot wait to connect with you on the next episode of Promising Young Surgeon.